Hi, welcome back. This is Module 4, Exercise, Stress, and Glucose Monitoring. My name is Cindy Head, a registered dietitian and certified diabetes educator. First of all, let's talk about physical activity. The benefits of physical activity, it can improve blood sugar control, lowers cardiovascular disease risk factors, can promote weight loss. What's recommended for weight loss is approximately 60 minutes per day. Promote sense of well-being, may prevent type 2 diabetes in high-risk individuals. Slower decline in mobility is associated with more physical activity in the elderly. It improves insulin action. Its effects can last anywhere from 2 to 72 hours. It improves fat oxidation and storage in muscle. A lower LDL cholesterol is often associated with exercise, as well as a lower blood pressure. And it can improve depression symptoms. A single session of aerobic activity increases insulin action and glucose tolerance for up to 72 hours. It may lower A1C by approximately 0.66% in people with type 2 diabetes. Normal exercise physiology in the healthy individual, the rate of appearance and disposal of glucose is essentially equal during exercise of moderate intensity and duration. Prolonged exercise or sufficiently intense exercise can result in an imbalance leaning towards a higher rate of glucose disposal than appearance, at which point glucose levels fall along with the onset of fatigue. The rate of glucose appearance is dictated by the amount of glucose being absorbed at the gut as well as hepatic glucose output. The liver is capable of catabolizing stored glycogen as well as synthesizing new glucose from specific reduced carbon molecules such as glycerol, pyruvate, and lactate. And that process is called gluconeogenesis. Unlike skeletal muscle, hepatocytes contain the enzyme glycogen phosphatase. This enzyme removes a phosphate group to release free glucose. In order for glucose to exit a cell membrane, the removal of this phosphate group is essential. So although gluconeogenesis is an important component of hepatic glucose output, it alone cannot sustain exercise. For this reason, when glycogen stores are depleted during exercise, glucose levels fall and fatigue sets in. Glucose disposal is controlled by uptake of glucose at the working skeletal muscles. During exercise, despite decreased insulin concentrations, muscle increases GLUT4 translocation and therefore glucose uptake. Glucose control, as mentioned above, insulin secretion is reduced during exercise and does not play a major role in euglycemia during exercise. Insulin's counter-regulatory hormones appear in increasing concentrations during physical activity. The principal hormones among these are glucagon, epinephrine, and growth hormone. All of these hormones stimulate hepatic glucose output. For instance, both epinephrine and growth hormone, they also stimulate adipocyte lipase, which increases non-esterified fatty acid release. By oxidizing fatty acids, this spares glucose utilization and helps to maintain euglycemia during exercise. In a situation of elevated plasma glucose or hyperglycemia, moderate exercise can induce greater glucose disposal than appearance, thereby decreasing total plasma glucose concentrations. As stated, the mechanism for this glucose disposal is independent of insulin, which makes it particularly well suited for people with diabetes. In addition, there appears to be an increase in sensitivity to insulin for approximately 12 to 72 hours post-exercise. This is particularly useful for those who have type 2 diabetes and are producing sufficient insulin but demonstrate peripheral resistance to insulin signaling. However, during extreme hyperglycemic episodes, people with diabetes should avoid exercise due to potential complications associated with diabetic ketoacidosis. Exercise could exacerbate ketoacidosis by increasing ketone synthesis in response to increased circulating non-esterified free fatty acids. It is recommended to avoid exercise until ketones are no longer present. So, in summary, what needs to be taken away from this is the higher the intensity of physical activity, the greater the amount of carbohydrate utilization, and then the greater improvement in A1C. It is very important that we teach our patients to be evaluated by a physician before beginning any exercise program. The glucose lowering effects occur because of a decrease in muscle glycogen, which causes more space to store glucose in the muscle. Glycogen is used up very quickly, and there is a prolonged increase in glucose uptake by the muscle. Glucose lowering effects of exercise. First of all, it causes a decrease in muscle glycogen, which means there's more space to store glucose in the muscle. Glycogen is used up very quickly. Muscle conditioning can increase insulin signaling and glucose metabolism, and it improves insulin sensitivity while decreasing cardiovascular disease risk factors. An evaluation by a physician is recommended before beginning an exercise program, and it's something you always want to teach your patients to do before they start anything new. And what needs to be assessed is the physical condition and limitations of the patient, such as orthopedic problems, high fall risk, sedentary lifestyle, things such as that. And then assess blood glucose control, knowledge of physical activity in relation to blood glucose control, and when making a referral, make other healthcare clinicians aware of the patient's limitations for exercise. Assess for conditions such as uncontrolled hypertension, autonomic neuropathy, severe peripheral neuropathy, history of foot ulcers, and unstable proliferative retinopathy. There is no evidence to suggest that a stress test is needed in asymptomatic patients before beginning a moderate intensity exercise program. However, it should be considered in previously sedentary patients at moderate or high risk for cardiovascular disease or other patients who are clinically indicated. So consider an ECG stress test if a patient is greater than 40 years of age with or without cardiovascular disease risk factors. Anyone greater than 30 age with type 1 or type 2 diabetes of greater than 10 years duration, hypertension, cigarette smoking, dyslipidemia, proliferative or pre-proliferative retinopathy, and nephropathy. Also consider any of the following. If a patient has a known or suspected coronary artery disease, cerebrovascular disease, or peripheral artery disease, if they have autonomic neuropathy or advanced nephropathy with renal failure. Physical activity guidelines in adults, 150 minutes per week of moderate intensity aerobic activity is recommended. That's 40 to 60% of the maximal aerobic capacity, or 75 minutes per week of vigorous intensity, which is greater than 60% maximum aerobic capacity. This exercise regimen needs to be spread over 3 days per week with no more than 2 consecutive days without activity. Children with diabetes or prediabetes, 60 minutes each day. Doesn't seem hard for children to get 60 minutes each day, but I see a lot of kids with type 2 diabetes, and part of the reason is they're becoming more sedentary, watching more TV and playing more video games. Minecraft, that's what my son plays. Examples of aerobic activity. And aerobic activity is any form of exercise that uses large muscle groups and causes a sustained increase in heart rate. Things like walking, jogging, bike riding, swimming, and dancing are forms of aerobic activity. Intensity matters, and when I teach my patients, I like to teach the talk-sing test so that they can measure their intensity. So if the patient is unable to talk during activity, then they're going too hard and they need to slow down. If they're able to sing, then they're not going hard enough. And that's just an easy way to help them learn what intensity they should be doing their aerobic activity. Resistance training is recommended 2 times a week using free weights, weight machines, or resistance bands, and it should involve large muscle groups in the upper body, lower body, and core region. 1 set of 5 or more resistance exercises is recommended with 10 to 15 repetitions to near fatigue per set in the beginning, and then progressing to heavier weights and less repetitions over time. And what resistance training can do is it can lower fasting glucose levels for up to 24 hours after activity in a lot of patients with impaired fasting glucose or prediabetes. It's inconclusive whether or not you have to have resistance training, but I think a lot of studies are finding that a combination of aerobic and resistance training may be better and more beneficial than just doing aerobic activity or just doing resistance training. So it's good to have both in your exercise plan. Physical activity with hyperglycemia. In someone with type 1 diabetes and ketotic, exercise can worsen ketosis, so it is recommended to avoid vigorous activity if ketones are present. The patient needs to rest, drink plenty of fluid. It is okay to exercise, however, when hyperglycemic without the presence of ketones. Once the blood sugar is greater than 300, that increases the chances of dehydration. And so you really need to encourage the patient to stay hydrated if they're going to exercise when they're hyperglycemic. Physical activity with hypoglycemia. Exercise can cause low blood sugars, especially in patients taking insulin or insulin secretagogue medications. The risk increases with the duration of the exercise. So longer exercise regimens tend to have a higher risk of hypoglycemia. Regimens that are higher in intensity also can increase risk. So it's recommended that exercise during peak insulin times be avoided, because that's when also an elevated risk occurs for hypoglycemia. It's also recommended that exercise be done either after a meal or wait for the action of the insulin, for the peak of the insulin to start wearing off before performing the activity. Risk of hypoglycemia decreases with fitness level. People who monitor their blood sugar before and after exercise typically don't have as frequent hypoglycemic events. And then injecting insulin in sites other than exercising muscle can also prevent hypoglycemia, because if you inject it in exercising muscle, it tends to make the insulin work more rapidly. Strategies for preventing hypoglycemia: dose adjustment may be needed if weight loss occurs, and that is something that I teach my patients when I talk about exercise, is that a lot of these diabetes medications are dosed based on body weight, and as weight loss occurs, less insulin is typically needed to control blood glucoses. Obviously, as mentioned earlier, I teach them to avoid exercise during peak action of insulin. I also stress the importance of monitoring their blood sugar before, during, and after to determine the effect of the exercise on their glucose level. And this isn't forever. You know, patients are very quick to figure out how they respond to certain levels of activity. And so, but at the beginning, I do stress the importance of monitoring a lot more frequently when you start a new exercise program. Eat a snack if blood glucose is less than 100 milligrams per deciliter prior to the exercise. There is less risk of hypoglycemia if exercise is performed after a meal. I do teach them to carry fast-acting carbohydrate and a snack with them. They just need to make sure they've got a treatment for hypoglycemia with them in case it happens. I also teach them to avoid alcohol consumption on an empty stomach and to carry a form of medical identification in case something were to happen. Physical activity with long-term complications. Patients who are at high risk for cardiovascular disease need to begin activity with very short periods of low intensity. And then the intensity can increase, but it needs to increase slowly, and the duration needs to increase slowly. It may be safer for individuals at high risk for cardiovascular disease to be supervised in a cardiac rehab program. That way they can be monitored by a nurse and exercise professionals who know what to do in case something happens. Now for nephropathy, there is no exercise restriction. So exercise is safe for patients with diabetic kidney disease. Retinopathy. Exercise may be contraindicated due to risk of vitreous hemorrhage and retinal detachment, and should be avoided, or exercises that cause intraocular pressure and hemorrhage risk should be avoided in patients with proliferative retinopathy. Examples of exercises that could increase intraocular pressure would be weightlifting. A lot of your resistance training would, and then running can also do that. Patients with diabetes should be under the care of an eye doctor before beginning an exercise program. They should receive an annual dilated eye exam to assess for retinopathy. Peripheral neuropathy, it's important to take care of your feet when exercising, and in some patients, exercise may need to be avoided, or certain types of exercise may need to be avoided, because when you've got neuropathy, it increases the risk of skin breakdown, infection, and then the Charcot joint destruction in the feet. Certain forms of activity may need to be avoided. Obviously, running would not be a good exercise. It puts too much pressure on the feet. But studies are showing that moderate intensity walking may be safe and beneficial in patients who have mild neuropathy, as long as these patients are taught how to properly care for their feet, such as wearing proper footwear to protect their feet from foot ulcer or from damage. And they need to know to examine their feet daily to detect ulceration early and seek treatment for that. Autonomic neuropathy increases the risk of injury and adverse events due to low cardiac responsiveness to exercise, postural hypotension, impaired thermoregulation, impaired night vision, and there is a greater risk for hypoglycemia in these patients. It is very important that patients with autonomic neuropathy investigate their cardiovascular health before beginning an exercise regimen because they are at higher risk for silent heart attack and cardiovascular death. So, strategies for increasing physical activity. Start slowly. That's one of the most important things. Most of our patients with type 2 diabetes are sedentary and overweight, and they'll become very overwhelmed if you tell them, do 150 minutes a week. It may be easy for you or I to do that, but not easy for many of our patients to do that. So stress with them the importance of starting slowly by incorporating 10 minutes of increased activity into each day. I had a truck driver as a patient the other day, and he's got a very strenuous truck driving schedule. I told him every time he stops for a bathroom break that he needs to park farther away from the bathroom and get some extra steps in that way to help him increase the physical activity. Help them overcome barriers. I think one of the biggest barriers these days is stress. We're stressed for time, I think. We live very busy lives and have busy schedules. And I think what helps overcome that particular barrier is to have a plan. I think patients who plan exactly when they're going to exercise, exactly what they're going to do, are the people who tend to be the most successful at sticking with it. Obviously, self-monitoring of the activity helps to promote compliance with it. Pedometers are a great tool to help people see their progress. And what's recommended is 10,000 steps a day. And I'm pretty physically active, but 10,000 steps a day is hard for me to get sometimes. And it's really gets me motivated to work harder. Keeping a time record or a journal is also good. It helps patients be able to look back and see where they were and how they've progressed over time. That's always beneficial. Patients need to be consistent. Once you get out of a habit, it's hard to go back. And so we want our patients to develop exercise as a habit that they have for a lifetime. Have alternate activities for inclement weather. It's snowing here now. Actually, it's freezing rain here now. And some of my patients go to the mall when there's bad weather outside and do their walking there. Find enjoyable activities. Many of my patients join the Y and they go to the pool and swim or go to the aerobic classes. It doesn't matter as long as what they're doing they enjoy. That's important. And then be active at the time of day that is best for the individual. You know, you always hear people say, well, it's best to exercise in the morning. I'm not a morning person. The thought of exercising in the morning for me personally makes me cringe. I do much better in the evening. At least, even though in the evening may not be as beneficial to my metabolism as doing it in the morning, at least I'm doing it. And that's the way our patients need to look at it as well. And then physical activity with a partner who can hold you accountable is also associated with improvements in patients' compliance with an exercise regimen. So I always ask patients to think of a friend or find a friend they can go to the gym with. Strategies for increasing physical activity, how to work it into your daily life. Walk to your mailbox. Stop using TV and other remote controls. Now, a lot of my patients laugh at me whenever I tell them that, but I grew up in a time when you didn't have a remote control for your TV. You had to get up off the couch to change the channel, and you had a dial that changed the channel. I'm showing my age here. But put the remote away. Get up. That'll help. Vacuuming, cleaning the house, playing with the kids. I always said if I could just follow my kids around 24/7, I wouldn't have to worry about my weight. Make the beds. Use the stairs instead of the elevator. Park away from a building entrance. Walk to do errands. So there's lots of ways we can incorporate more activity. We just have to think about it. Exercise safety. Wear proper footwear. Break new shoes in before wearing them during exercise. I've seen some really bad foot ulcers develop from brand new shoes that shouldn't have been worn during an exercise regimen. Wear diabetes identification bracelet. Hydrate with 17 ounces of fluids before the activity and stay hydrated during the activity. Avoid exercising in extreme temperature environments. Don't exercise in the really, really hot temperatures because you could get dehydrated. It's also important to tell our patients not to exercise too much in really, really cold temperatures either. That can lead to more cardiovascular problems. Supervised training programs tend to promote greater compliance and blood glucose control because they provide accountability to the patient. It's important that we as healthcare professionals focus on developing confidence in our patient and what they feel about their ability to exercise. They may need education about how to operate equipment, what classes are appropriate for them, etc. Many people are ashamed of their appearance, especially women. They don't want to get in a bathing suit and take a water aerobics class. We need to be empathetic of that. At the same time, we need to keep stressing that exercise is about making your body healthier. It's not about winning a beauty contest. We need to foster support from family, friends, and healthcare providers and reinforce the ongoing needs and benefits of activity every time we see our patients. And we need to offer support and advice. So it's something we just need to constantly be talking to them about. Okay, moving on. Let's talk now about stress management. Stress is any process, externally or internally, that demands a response from the individual. It can be positive or negative. Positive stress can have an effect on blood glucose levels, so can negative stress. When we go through times of stress, our body develops hormones that affect glucose control. Catecholamines, which are epinephrine and norepinephrine, counteract and suppress insulin secretion by lowering the rate of glucose uptake. Epinephrine enhances glycogenolysis. When epinephrine or norepinephrine are present, it can make our glucoses higher. Glucagon stimulates gluconeogenesis. It causes the liver to release glucose stores. Growth hormone limits glucose transport into tissue, so it affects the way glucose is metabolized. And then cortisol limits glucose transport and stimulates gluconeogenesis. So we've got all these hormones raging during stressful times, and it does impact our ability, or a person with diabetes, their ability to manage their glucoses. Like I said earlier, stress, whether it's good or bad, makes the blood sugar higher a lot of times. Extreme physical stresses such as surgery or illness also influences glucose control. Depression affects glucose control as well. And people who experience depression and have diabetes have a 20 to 25% higher risk of having a heart attack. Causes of diabetes distress. A lot of people with diabetes live in fear that their diabetes is getting worse. And I do have people tell me that a lot, especially people who have been threatened with the chance that they're going to have to go on insulin. Often they'll view insulin as a last resort medication because their grandmother went on insulin after she already had a bunch of diabetes complications and didn't live very long afterwards. So I notice a lot of fear in people regarding that. And that's one of the things I try to tackle right up front is insulin is just insulin. It's replacing a hormone your body can't make as well anymore. And it's there to keep you from ending up like grandma, not to get you there sooner. People are also afraid that they can't do what they want. They live in fear of low blood sugars. They don't know what to do for high blood sugars. That can cause distress. They're worried about family responsibilities, worried about their weight, worried about becoming hypoglycemic. Insulin is expensive. Many of the newer diabetes drugs, the pills are expensive, and people struggle with their ability to afford their medications and testing supplies. They're unable to afford to eat healthy. Some people don't have much support from family and friends, and that is a very important piece of controlling diabetes. In my experience, the most successful people with their diabetes have been people with good family or friend support. Other issues that may impact their self-management, the patient's attitude about their illness, their medical management and outcome expectations, their anxiety level, general and diabetes-related quality of life, their resources, and their psychiatric history. What are the effects of diabetes distress? It is linked to A1C, self-efficacy, dietary compliance, exercise behaviors, and medication taking. Psychological problems may occur when medical status changes, when a patient starts taking insulin for the first time, or when there's a discovery of a diabetes complication. Foot ulcers can be an eye-opening thing to patients. A heart attack. Sometimes patients don't take their diabetes seriously until they have a heart attack or they have a stroke. So, but it is a cause of diabetes distress and affects the patient and their attitude and how they feel about taking care of their diabetes. If treatment goals for diabetes are not met, it is important to assess barriers such as income, health literacy, diabetes-related distress, depression, and competing demands. Opportunities for screening for depression or stress occur at diagnosis, at regularly scheduled management visits, during hospitalizations, the discovery of complications or problems with anytime there's problems with control, quality of life, or self-management identified. Let's talk about depression. People with diabetes do have a higher risk of becoming depressed or dealing with depression sometime during the course of their illness. But some of the symptoms include feeling sad or empty, feeling hopeless, irritable, anxious, or guilty, loss of interest in favorite activities, feeling very tired, not able to concentrate or remember details, not being able to sleep or sleeping too much, overeating or not wanting to eat at all, thoughts of suicide or suicide attempts, frequent aches and pains, headaches, cramps, or digestive problems. Just thought I would add some screening tools that you can go to and look at and even use in some of your diabetic patients. When is it appropriate to refer to a mental health specialist? And it is important that when you're considering a referral to a specialist, that the specialist has been trained in care for diabetes patients. But it is recommended in people with diabetes who are experiencing depression or suicidal ideation, people who have a problem with non-compliance with their medical regimen, especially those in which you know they've had the training they need, you know they understand what to do, they're just not doing it. Those who have severe anxiety, eating disorders, or people with impaired judgment due to cognitive decline would also be appropriate for a mental health specialist. Stress and depression management should be a part of diabetes self-management education. And what we need to focus on is teaching our patients how to manage stress. Exercise is one of the best things we can do to manage stress. But we also can focus on relaxation training. Medication does work, and there is a stigma with medications for depression. A lot of patients feel ashamed to start on an antidepressant. And that's always something that I try to clarify with patients when I'm talking to them. Visualization, biofeedback is a way to manage depression, helping them find a hobby they enjoy, psychotherapy, cognitive retraining, support groups, faith groups. Talk to the patient. Everybody is going to have an individual idea of what they feel like will help them manage their stress. Strategies to help meet diabetes self-management goals. Education programs are very beneficial. I think the more educated the patient is about their diabetes, the less diabetes distress they often have about it, because they're going to know what to do for a blood sugar that's over 300 or for a blood sugar that's less than 70. They're going to know and feel confident that they know how to take their insulin appropriately. So education is extremely important. Referrals to social workers to help with cost. There are a lot of programs out there. People can get insulin through the drug company if they qualify. There's lots of different things a social worker can do to help patients get what they need. Assessment of medication taking behaviors. That's important. We need to assess their routine, how they take their medication, and see what kinds of things we can do to help make that easier for them. Initiation of or increase in self-monitoring blood glucose, use of continuous glucose monitoring, more frequent contact with patients, and then referral to a mental health professional or endocrinologist if needed can also help. Okay. Let's talk about glucose monitoring. Thought I would start by reviewing the ADA target A1C and glucose goals. A1C goals would be less than 7%. Preprandial capillary blood glucose goals are 70 to 130. Plasma glucose would be 3.9 to 7.2. Peak postprandial would be less than 180 milligrams per deciliter, and then capillary plasma glucose is less than 10 millimoles per liter. Glucose goals should be individualized. Based on the patient's duration of diabetes, their age, life expectancy, comorbid conditions, their risk of cardiovascular disease, unawareness of hypoglycemia, and so on. For instance, it would not be safe for an elderly person to have really tight blood sugar control because they're at higher risk for low blood sugars due to their age. And we're not going to be as worried about chronic complications in an elderly person. Whereas a person in their 30s or 40s, we would be or strive to have better glucose control, tighter glucose control, to prevent the chronic complications of diabetes down the road. Lowering A1C to below or around 7% is shown to reduce microvascular complications of diabetes, and if implemented soon after the diagnosis of diabetes, is associated with a long-term reduction in macrovascular disease. And so that's why the ADA says a reasonable A1C goal is less than 7. Higher bedtime goals may be needed, especially for those at higher risk of nocturnal hypoglycemia, such as patients with type 1 diabetes or those with type 2 diabetes receiving insulin therapy, young children, and the elderly. Blood glucose goals postprandially. The goal is to try to achieve a blood glucose of less than 180 1 to 2 hours after the beginning of a meal. The greater contribution in postprandial hyperglycemia has a greater contribution in A1C levels closer to 7%, meaning if you have a patient who has fasting blood glucose levels within the normal range, and you notice their A1C is over 7, it may be a postprandial issue that would need to be dealt with versus increasing their Lantus or other medication that would affect their premeal or fasting blood glucose levels. I want to talk briefly about home glucose meters and the difference between plasma measures and whole blood measures. A plasma reading is what most meters today read. Whole blood was the old way of monitoring. Because the results of blood samples taken from your vein at the doctor's office or lab are reported as plasma, by having meter record results as plasma glucose, it became easier to compare lab tests with blood glucose meter results. So today, again, most newer meters are plasma. The difference really is that plasma numbers read about 10 to 12% higher than the older whole blood numbers. So if the plasma and the premeal blood glucose target is 90 to 130 on a whole blood glucose meter, that would be 80 to 120 as a target. It is important to know if the meter the patient is using reads plasma or whole blood, and then what targets to use with that. Advise the patient to check their instruction book, contact the manufacturer of the meter, or use the toll-free number on the back of their meter if they need assistance figuring it out. But like I said, for the third time, most of our meters today are plasma or measure plasma. Self-monitoring blood glucose is a component of effective therapy. Several diabetes management strategies reliant on self-monitoring blood glucose testing have demonstrated improved glucose control in patients. It is recommended that more than half of plasma glucose readings should fall in the desired goal range. Bedtime glucose goals vary depending on the patient's treatment program, risk of hypoglycemia, and time after their last meal. Self-monitoring blood glucose is a component of effective therapy, and improved glucose control in patients using multiple dose insulin or insulin pumps. It allows evaluation of response to therapy. It allows the patient to assess whether their glucose targets are being achieved, particularly their prandial targets. It's useful in preventing and detecting hypoglycemia and hyperglycemia. It's also useful for adjusting medications, medical nutrition therapy, and physical activity. There is a correlation between blood glucose testing frequency and a lower A1C. Now, for people with type 2 diabetes who are not on intensive insulin regimens, the optimal frequency of testing is unknown, but it still may facilitate reaching glucose goals, so it is still recommended in people with type 2 diabetes who take medication. Because the accuracy of self-monitoring blood glucose is instrumental and user-dependent, it is important for healthcare clinicians to evaluate each patient's monitoring technique and accuracy of their equipment. In addition, optimal use of self-monitoring blood glucose requires proper interpretation of the data, and patients should be taught how to use the data to adjust their food intake, their exercise plan, or their medication therapy to achieve their desired glycemic goals. The frequency and timing of self-monitoring of blood glucose depends on the particular needs and the goals of the patient. Patients with type 2 diabetes on insulin typically need to perform glucose testing more frequently than those who do not use insulin, particularly if using glucose readings to guide their mealtime insulin dosing. It is recommended that patients using multiple insulin injections perform self-monitoring blood glucose testing 3 or more times a day. And what's recommended is prior to meals and snacks with occasional postprandial testing. Some patients may need to check their blood sugar at bedtime, especially if they are prone to nocturnal hypoglycemia. It's recommended they test prior to and after exercise, when they suspect low blood glucose, after treating low blood glucose until they are normoglycemic, and prior to critical tasks such as driving. The optimal frequency and timing of glucose testing for patients with type 2 diabetes on oral agent therapy is not known, but should be sufficient to facilitate reaching their glucose goals. Glucose testing should be performed more frequently when adding or modifying therapy. And 2-hour postprandial testing is useful in some patients. The role of self-monitoring blood glucose in stable diet-related patients with type 2 diabetes is not known. The optimal frequency and timing of monitoring blood glucoses for patients with type 2 diabetes on oral agent therapy are not known, but should be sufficient to facilitate reaching their glucose goals. Glucose monitoring should be performed more frequently when adding or modifying therapy. A 2-hour postprandial glucose testing is useful in patients adhering to treatment regimen but unable to reach their A1C target goals. And then fasting glucose readings are useful for titration of basal insulin doses. The role of blood glucose monitoring in stable diet-treated patients with type 2 diabetes is not known. Let's talk about pattern management, because in order to make a good decision about adjusting a patient's medication regimen, you need to look for trends or patterns in their blood glucose control. So it's very important that the patient keeps log books or downloads their meter on a computer so that they can show you a written copy of their blood glucose results and making it easier for healthcare professionals to look at trends or to look for patterns. But pattern management is a comprehensive approach to managing glucose levels, and it's good for interpreting blood glucose trends. It also allows for more comprehensive assessment and management of medications, nutrition, psychosocial issues, and exercise. It's dependent upon records provided by the patient, and accurate records are extremely important. Before meal testing trends can be used to monitor basal and corrective insulin doses. After meal trends can be used to determine the effectiveness of medications and diet. Fasting blood glucoses can be used to investigate the dawn phenomenon or SMBG effect. In the hospital, we do a lot of 3 a.m. testing just to look for those problems. So I wanted to go through a couple of scenarios with you just to hone your skills on interpreting the data. So in this first example, as you can see, the fasting blood sugar tests before breakfast are within the ADA target parameters. The tests before lunch and supper are also within target parameters. However, for 3 days in a row, the test results before bed are much higher than they should be. So knowing a little bit about how Novolog and Lantus work will help solve this problem. Novolog is a fast-acting insulin. It starts to work 5 to 15 minutes after a shot and lasts 3 to 4 hours. Lantus is a long-acting insulin that begins to work about 1 or 2 hours after a shot and continues working in the body for 20 to 24 hours. Eating a larger amount of carbohydrate at dinner or not taking enough fast-acting insulin before dinner could be causing a spike in the bedtime blood sugar 4 hours later. So a possible solution to this problem would be to look at how much carbohydrate this particular patient is eating at dinner and consider eating less carbohydrate at that meal, or teach the patient how to adjust their dose so that they know how to take an extra unit or two of rapid-acting insulin to cover the extra amount of carbohydrate that they are eating at that supper meal. In the second example, as you can see, the blood sugars are close to the ADA target parameters most mornings, except for when the patient had pizza, pie, or ice cream at dinner the night before. On those mornings, the blood sugar was higher. The blood sugar was also higher before going to bed the night the patient had the pie and ice cream. So what does this pattern show? This pattern shows that when the patient makes good food choices, obviously, the blood sugar stays close to target. When the patient eats high calorie or high carbohydrate foods, the blood sugar goes up too high. What is a possible solution to this problem? A solution would be to teach the patient to stop eating high calorie foods such as pizza, pie, and ice cream, or to eat these foods but in smaller amounts. Another solution could be to teach the patient to exercise after eating these foods to burn off the extra calories. User error is the most common reason why a patient would have unreliable glucose testing results. An inadequate blood sample is a common cause of unreliable results, and errors in subsequent treatment decisions. I've also had patients get unreliable results because they didn't let their hand sanitizer dry thoroughly, or the rubbing alcohol they used to clean their fingertip dry before performing the finger stick, and that alcohol or that hand sanitizer got mixed in with the blood sample. An individual needs to know when it is not safe to use alternate site testing. Most home glucose meters are approved for alternate site testing. The most common places to do alternate site testing would be the top of the arm or the palm region. Every meter brand has their own specific approved sites, so it's important to teach the patient to read their instruction manual before they would start the alternate site testing. Alternate site testing has a lag time and is about 15 to 20 minutes behind a finger stick result. And so it shouldn't be used if someone is having a hypoglycemic or a severe hyperglycemic event. Anytime you need a more accurate result, you don't want to use an alternative site to do the blood sugar check with. Hospital glucose meters. I know the meter we use in the hospital here is not approved for alternate site testing. I'm not sure any hospital meters are. I think most require finger stick only or draw from an arterial line. In my experience, patients who are frequently testing blood sugars, 3 or 4 times a day, complain of their fingers hurting, and that those patients are very receptive to learning more about alternative site testing. Alternative site testing means using a part of the body other than the fingertip to obtain blood for blood sugar testing, and it's usually the alternative sites that are approved for most meters would be the forearm or the palm. Some studies show that the accuracy of routine testing before meals and 2 or more hours after meals from alternate sites is equivalent to the fingertips. Alternate site testing must be performed with a meter approved for alternate site testing. The individual needs to know when it is not safe to use alternate site testing. The alternate site testing should not be used during hypoglycemic or severe hyperglycemic events because glucose arrives faster in the fingertips than in the arms. Glucoses that are falling rapidly or rising rapidly are likely to be less accurate using alternative site testing. Therefore, the fingertips should be used for all non-routine testing. But any routine testing, it is okay to use the alternative sites. With my patients, if they're newly diagnosed, I don't recommend they start alternate site testing until they have gotten their blood sugars under fairly good control. It's important that a patient receives regular evaluation and teaching. It's important for healthcare clinicians to evaluate their monitoring technique, the accuracy of their equipment, and interpretation of the data. We need to remember to teach them how to use their data to adjust their food intake, their exercise, and their medication therapy. It's also important that we provide ongoing instruction and evaluation of their technique, their results, and their ability to use the data to adjust their therapy. I always teach patients, and I carry logbooks with me. I teach them, write your numbers down, take that to your physician to evaluate. And so often patients will say, well, I take my numbers, but my physician doesn't look at them. And that's something that I think we as clinicians, as healthcare providers, whether we're nursing, pharmacists, whatever, we need to get in the habit of looking at numbers. That's really what's going to help us make appropriate therapeutic changes. So some pearls for practice. Appreciate a global definition of monitoring. Demonstrate empathy for the additional work of patients. Embracing monitoring. Make certain a patient understands how to set the depth on their lancing device so that it doesn't hurt as much when they do their stick. Teach a technique for obtaining an adequate blood sample to minimize bruising. Teach not just how, but teach why. So often, we get caught up in teaching them how to use the equipment, but forget to teach them why it's important for them to use their equipment properly, to keep their equipment clean, why it's important that they're testing their blood sugars in the first place. Set realistic and individualized goals and help patients make the data work for them. A1C testing. And A1C is an average blood sugar over a 60 to 90 day time period. The benefits of A1C testing: it can provide a check on meter accuracy and patients' reported results. And it can also help us assess the adequacy of the blood glucose testing schedule the patient may have at home. It is a strong predictive value for diabetes complications. The higher the A1C, the greater the risk of complications. It can help us determine if blood glucose values have been reached and maintained. The table on this slide shows the correlation between A1C levels and mean plasma glucose. It is beneficial when speaking with patients about their A1C to relate it to the estimated average glucose. I can tell a patient all day long their A1C is 7. It really doesn't mean anything to them until I explain to them that a 7 A1C means their estimated average blood glucose is about 154 milligrams per deciliter. A1C testing should be performed routinely in all patients with diabetes at initial assessment and then as a part of continuing follow-up care. Obviously, the frequency depends on the clinical situation, their treatment regimen, and the clinician judgment. Typically, patients meeting treatment goals should have their A1C tested at least twice a year. Patients whose therapy has changed or who are not meeting glycemic goals should have quarterly testing. This helps to determine whether a patient's glycemic targets are being reached and maintained. It also helps a clinician make timely decisions on when to change their therapy. There are some limitations of an A1C test. Conditions that affect erythrocyte turnover, such as hemolysis, blood loss, and hemoglobin variance, can cause an unreliable A1C result. When I see an A1C result that's below 6 in a patient that I'm evaluating in the hospital, I automatically look at their hemoglobin level, because if their hemoglobin is low, there's a pretty good chance that that A1C result is not reliable. It probably is a lower number than what their blood sugar actually has been running at home. It also does not provide a measure of glycemic variability or hypoglycemia. I've had patients in the past who their A1C looks good. You know, it might be 6.8, 7%. But I could tell by looking at their blood glucose records that doesn't mean that they're not in good control, because their blood sugars will be 50 sometimes and they'll be 300 sometimes. And so because of the extreme variability, the average looks good. However, they're not in good control. So you've got to be careful that you're really looking at their blood glucose results they're getting off of their meter as well as their A1C. An A1C of less than 7% equals less microvascular complications, less macrovascular complications if started soon enough after diagnosis, and is a reasonable goal for most adults who have diabetes. An A1C of less than 6.5 may be appropriate if it doesn't cause significant hypoglycemia or adverse effects. Appropriate patients may include people who have had a short duration of diabetes, people who have a long life expectancy, and people who don't have a significant cardiovascular disease risk. And then an A1C of less than 8 may be appropriate for those with a history of severe hypoglycemia, those with limited life expectancy, people who have advanced microvascular or macrovascular complications, people with extensive comorbid conditions, or those with a long history of diabetes that have had difficult to attain goals despite compliance with glucose monitoring, their medications, their diet, and their physical activity plan. Let's talk a little bit about continuous glucose monitoring. This is used with intensive insulin regimens. It measures interstitial glucose in real time. Interstitial glucose correlates very well with plasma glucose. People who use continuous glucose monitoring wear a sensor, and they'll wear it for a number of days to measure their blood glucose. It does not replace their need to use their glucose meter to perform blood sugar checks. In fact, self-monitoring blood glucose is needed at least twice a day to calibrate their sensors. It's also needed anytime acute treatment decisions need to be made. So the sensor may alarm when a patient's blood glucose is low. However, the patient would still need to use their home glucose meter to do a finger stick and check their blood sugar before they make a treatment decision. Continuous glucose monitoring is useful to lower A1C in selected adults who are greater than 25 years of age and have type 1 diabetes. The evidence for A1C lowering is less strong in children, teens, and younger adults. Success typically correlates with adherence to ongoing use of the device. And children and teens tend not to adhere as well as adults do. It is a supplemental tool to self-monitoring blood glucose in those with hypoglycemia unawareness and or frequent hypoglycemic episodes. The CGM devices alarm for hyperglycemic and hypoglycemic events. There is no significant difference, however, in frequency or severity of hypoglycemic events, but it is still useful for hypoglycemic unawareness and or frequent hypoglycemic episodes. That concludes the Module 4 presentation. I was glad that I got to speak with you guys in Module 3 and Module 4. Go ahead and complete the study guide, and I will talk to you soon.